Hello, everyone. Today on Gracefully Graying, we have a great guest for you, and we want to be sure that you watch us on YouTube, on our YouTube channel by visiting Gracefully Graying and going to our website, gracefullygraying.com. Today, we are very honored and excited to have our guest, Aliya Pasik from the Rochester Center for Behavioral Medicine. And Aliya is the Director of Addiction Medicine Program at the Rochester Center for Behavioral Medicine. And welcome, Aliya, to Gracefully Graying.
Thank you so much for welcoming me today. It's a pleasure to be here.
Yeah, so I know that we're going to talk about some important issues with the 50 and over demographic. First of all, tell us about your background and training.
So I got my undergraduate degree at Columbia University in New York City. And from there, I actually headed into a career in television news. I was a TV news reporter for 3 years after I graduated from Columbia. But I have to say that standing on the sidelines just didn't give me the same kind of fulfillment as rolling up my sleeves and getting involved. And I can tell you that from my years in the news business, we used to joke in the newsroom, if it weren't for drugs and alcohol, we'd have no job. And that just goes to show how much these problems can really permeate society. It's not just a matter of your family's health or an individual's health, but this is an area of medicine. I feel that when I'm doing my job, I can actually lower the crime rate. So for me, I think that was a really smooth transition in terms of what that meant for me for personal fulfillment and making sure that I was actually helping and not just standing around and talking about it.
Yeah, that's an unusual, I'm sure there aren't many people that have made that transition similar to the one that you did. That's interesting. How did you become involved with the Rochester Center for Behavioral Medicine?
Well, after the news business, I actually went into pharmaceuticals, and I was there for about 9 years and became more and more interested in the science and pharmacology. So when I wanted to get even closer to it, I decided to go back to PA school, and I got my training at the University of Detroit Mercy. And there I really felt very connected to the field of psychiatry and addiction medicine because we had an excellent speaker who came in and said, if you want to prevent addiction, treat ADHD. If you want to heal addiction, treat ADHD. And the general idea behind it was you can really help these people by helping them get over the pain, whatever that pain is, whether it's anxiety or depression or bipolar or schizophrenia. Any one of these can lend itself to a substance use disorder. So when I entered into PA school, I sort of had this idea in the back of my mind that I was interested in this. And now my first job out of PA school was within family medicine, doing addiction in the family medicine background. And I did about 14 months with a family practice in Madison Heights, and I felt that I would have more resources available to me in the psychiatric backdrop because I do feel that all addiction comes from something underneath, something underlying. And I say that people who are happy, healthy, and whole don't get hooked. So the mystery is what got them there? What discomfort was it? What ailment was it? What condition or what diagnosis lies underneath that could be lending someone to need to self-medicate?
Yeah, that's very interesting. So tell us specifically about your role as the director of the Addiction Medicine Program.
As the director, I see the majority of addiction patients in our clinic. I had my training at Maple Grove inpatient rehab, so I've seen it both from the inpatient and the outpatient perspective. So I'm familiar with the detox process and when it can and cannot be done outpatient. And I help make that determination. And if there are addiction patients in the clinic who I do not see, I will very often consult with other clinicians and give them guidance as to how to best manage their patients. But I also coordinate a number of other resources for patients as well, above and beyond just what we do in the office. I have a robust Vivitrol program for which I am able to be found under the National Registry of Vivitrol Providers. So Vivitrol is an injection given once a month to block the effects of opiates and alcohol. So when that is administered, patients have a significant decrease in cravings. And it really is an excellent tool for preventing relapse. Once they've been injected with this, it's a blocker for those receptor sites in the brain. So these substances can't get through and cause the damage that they do. And very often patients will hear that they can't get high. So they kind of have in the back of their mind, I'm not going to do this. I'm not going to waste my money. I'm not going to try this. So I have coordinated that as well. And a number of other things. I coordinate with the rest of our team and the colleagues for getting them into therapy and other additional services such as AA or smart recovery. So it really is a coordination of many different aspects of addiction.
Wow. Okay. So what types of substance abuse do you deal with specifically? Sorry.
Any and all substances, in fact, even some non-substances. I have, in my practice, most commonly been treating alcohol and then followed by opiates, and that can be either painkillers or heroin. And then I see gambling and sexual addiction as well.
Okay, kind of covers the gamut.
Well, there are some new ones out there too. There's a new one on the market called Kratom, and that's become a big issue, more so for the younger patients who are hooked on heroin, but they sell these in vape shops, these Kratom capsules, or they sell it like a tea. And 22 of the 35 compounds in Kratom are attaching to the mu opioid receptor in the brain, meaning it acts on the body and the brain like an opiate. And now this is available to the public without restriction. So that's been a new entrant into the addiction market as well, unfortunately.
Yeah, wow. Thanks for bringing that up. Obviously, it's important to educate the public on that because I'm sure most people don't know about that or don't know about that yet. Yeah. So, tell us about working with older patients, whether it's the 50 and over crowd, whether it's seniors, the needs of these patients, how they differ from working with younger patients, and the importance of communicating with them and their families, and the importance of open communication. Because I know that you really strive to do that. And tell us a little bit more about that.
Well, a lot of the issues that I see with seniors and substance abuse often relate to anxiety, and they come by this anxiety in a very honest way. They may have had physical problems, they may have mobility issues, they may feel any one of a number of other problems that make them feel very isolated. So keeping the lines of communication open are going to be very helpful. And asking your loved one, how are you feeling? Checking in today. What is your mood like? How are you feeling? What's your energy level like? Have you eaten? These are all basic questions that show and imply that you care. And I think that when patients feel isolated, alone, bored, even during times like this, they need the extra support. And I think it's very important when communicating to really take the shame out of it. I feel that a lot of my patients struggle with this greatly. Embarrassment, shame, these are all things that kind of keep a person in an addictive mode. Anything that lowers self-esteem is the enemy of sobriety. People who are confident are not using. It's a symptom of pain. And if people are having relief from the emotional pain or the physical pain that they're having, they'll be a lot less likely to relapse or even to start using
Right.
anything like that.
Right. Yeah, so important. So the issue of over medication due to pain management or depression seems like it's so prevalent these days. So discuss that issue of self-medication, and then the importance of maintaining the medications.
I think this is one of the most important aspects of helping our seniors with sobriety is pain management and doing it in a responsible way. And I think it's very important that family members go with your loved one to appointments. I have an excellent case to give an example. I had a man bring his mom in. She was in her 70s, and she had been seeing the same doctor for years and years and years. And she was beginning to have some falls. So her son was concerned that the medications that she had been on were no longer working for her. So when I brought her in and I assessed her and I saw what she had been taking, I really felt that what she had been on may have been the perfect combination some years ago. But I think that as we age, it's really important to do these kinds of check-ins with your doctor, especially if things are changing. If you are noticing things like your balance might be off, or you feel a little bit dizzy, or in the mornings you have a hard time going from laying to sitting or sitting to standing, these can all be symptoms of medications that are no longer age appropriate. Things that in our bodies don't seem to affect our cardiovascular systems when we're younger, as we age, that can really change quite a bit. Things can slow down the circulation a bit. You may not be able to get the blood from your legs to your head as quickly, and certain medications can certainly enhance that difficulty for patients. So making sure that the medications are not only the right doses for the patient, but that they're still age appropriate. You know, there is something put out called the Beers criteria, and that's a list of medications that should not be taken by patients over the age of 65. And I think that it's really important that patients can even ask their doctor, well, is this on the Beers list? I want to make sure that the medications that I'm taking are right for my age and it's the right dose for my age. Self-medication is a big problem, especially with painkillers. And if you have anybody that may have issues with memory, they may be in pain and not remember if they've taken medication. So this is something that's very important. You want to be using pill cases. You want to be having some supervision if your loved one may have memory problems, especially with pain, because very often pain isn't relieved by the first pill that you take, and that's when we can get into trouble. The way that medications can really wreak havoc on our seniors is the ones that can depress respiratory drive, meaning, do you still feel the urge to breathe, which is something we're naturally implanted with? But certain medications, such as opiates, and even some of the benzodiazepines, which are very commonly used for anxiety, can lower that drive to breathe, and that can be when people slip into an overdose situation. So it's very important to make sure that pain is managed with a combination of non-controlled substances and other non-medication modalities. I think is also very helpful. It's not all about the opiate and the mu receptor, which is where opiates attach to in the brain. So I like to try to remind my patients that there are very many pain receptors in the brain, and you don't have to be stuck on the opiate receptor.
Mm-hmm. Wow, it's all so complicated, and yeah, all intermingling. When you know, when you're working with seniors, I mean, what are you seeing the most of these days? If I could just ask that. I mean, is it as far as the substance abuse? Is it the medication? Is it the alcohol? Is it
Alcohol.
like it's alcohol?
Alcohol. I
And
see that
mm,
more commonly even than opiates. And
really?
sometimes tricyclic antidepressants. That's an interesting one as well. That's something that they use for sleep and pain. And I've seen patients overtake that with the consequence of low blood pressure leading to falls.
Hmm.
So that's a very serious one. The other one I feel is very serious are benzodiazepines. Anything that can cause you to lose your balance, I think is a great risk. And with benzodiazepines, patients will often feel anxious because they are alone or they are uncomfortable.
Hmm.
And they may take something, and if they get up to use the restroom during the night, it makes them more of a tripping hazard. And again, it can just suppress the drive to breathe. But additionally, I feel that sometimes certain medications, when you take them, may give you some relief for the moment. Other times when they wear off the next day, you may have a bit of a rebound, which may lend itself to patients wanting to take another one. And for patients who are more prone to something like that, where it isn't just an occasional anxiety or a panic here and there, but it can become more of that cycle and patients can end up needing more and more. So
Hmm.
that's definitely a vulnerability there.
Yeah. I mean, have you noticed an increase because of the coronavirus pandemic? I mean, have you seen your numbers go way
The
up?
increase in alcohol, the increase in alcohol has been significant.
Hmm.
I think people are feeling scared, people are
Yeah.
feeling lonely, people are feeling isolated. And the one that I hear a lot is bored. Boredom can really drive people into the worst of situations.
Right. No matter what age, doesn't matter. Young. Oh, I mean, it doesn't matter
That's
what age.
true. That's
Yeah.
true. And I often find that ADHD, regardless of age, is a trigger for substance use disorders. And ADHD is genetic in addition to other factors. So we carry that with us from birth till death.
Yeah.
But it appears different at various decades, like most diseases do.
Yeah.
And we can have seniors that have some hyperactivity, but they don't have the mobility to blow off that steam. And then that can become an inward sort of hyperactivity, racing thoughts, anxiety. And
Mhm.
they often reach for alcohol to calm that down.
Hmm.
So when you have ADHD, there's a lack of dopamine in the brain. That's the brain stimulant, and the brain is craving stimulation. So without it, people will seek stimulation from the highest source, whether they want it to or not. So that can be distractions or racing thoughts or the need to move. But in addition to that, the most stimulating thing for any human, ADHD or not, are pain, fear, sadness, and anger. And if you're older, these may be things that you're dealing with already. And if
Yeah.
you've got an underlying ADHD, those very stimulating emotions can trigger even more upset. And that can make somebody want to self medicate. In the
Right.
absence of dopamine, brain still needs another stimulant to tune out all the unnecessary info coming our way. So for that, we kick out adrenaline, fight or flight,
Hmm.
the running from the bear in the cave hormone. And that's really unpleasant. And oftentimes that is what prompts people to reach for alcohol.
Yeah. Wow. Okay. I mean, your explanation of that is, amazing and invaluable to people, I'm sure. Now, if someone has a family member that is struggling with addiction, talk to us about the importance of acknowledging that and validating that, the family with the patient, and tell us about that.
I think the most important thing when you are having this discussion with a family member is to take the quote unquote confrontation out of it, approach it very lovingly. We've noticed you're not yourself lately. We're concerned. We love you. What's going on? Why are you feeling this way? Why have we noticed this? What are you experiencing that has led you to be this way? I think if people can really take the shame out of it, they have a much better chance of recovery. When those around them realize that it's not a choice, it is a disease, it's not something they picked, it picked them, I think that recovery comes much more smoothly. Shame and addiction are absolutely undivorceable. When you feel low, you use. When you feel good, you don't. So, approaching your family member in a way that expresses love, concern, care, respect, you're going to have a much, much better chance of getting them into help if you make threats or ultimatums. People need to feel comfortable. And if they've been doing something for a long time and that's an unhealthy habit, it's going to be hard to shake that out of them. So, it's got to be done with a lot of support, caring, recognition of the struggle.
Hmm.
Oftentimes, people tell me that they feel very upset that once they've achieved some clean time, the response they get is, well, you should have done that anyway. You should have been like that from the get go. And I find that as a really negative thing to say to somebody who's early on or at any point in their sobriety, actually, because that person got to that point because they were suffering, not because they wanted to. People who are happy, healthy, and whole don't get hooked. That's what I always say to my patients. And numerous times they've said to me, I wish I never started. I wish I never tried it. But I tell them the addiction started before you ever tried it. The addiction started with the notion that this was a safe way to release your problems.
Hmm. Yeah, I guess, it's a good way of putting it. But Um, so tell us about your treatment program. I mean, how, so tell us maybe the steps, like how do you approach this? How do you start to help people?
Mhm. Well, my approach is really twofold. I work both medically and cognitively with my patients. The first is to stabilize them and make the determination whether or not they would be better as inpatient candidate or outpatient. Now, if anybody's ever had a seizure, that's going to be an inpatient detox. That's not something you can ever take a risk with. Benzodiazepines and alcohol can produce a fatal withdrawal due to seizures. So if anybody's ever had a seizure, it has to be done in hospital. If somebody is addicted to benzodiazepines, typically my rule of thumb is nobody over 2 milligrams or 2.5 milligrams of any one of the um, main benzodiazepines would likely be going inpatient because that is a dangerous withdrawal. Now, with alcohol, their level of motivation factors in, other health issues, other comorbidities can factor in. But if they're generally healthy, I like to give them a chance to detox at home because that's one less step they have to transition to if they're leaving a rehab facility. They've already been sober in their home. Sometimes that transition from rehab back to home can be a bumpy one,
Yeah. So,
especially since they're old reminders
yeah.
of triggers.
So let me ask you then, people suffering from alcohol, substance abuse, when you start to treat them and they're home, do you find that they generally live alone, or it could be the same if they're living with somebody, or do you find
It
differences?
varies greatly.
Hmm.
No, it varies greatly. In fact, I've seen it done from the gamut of circumstances, from people who are either living completely alone or living with families. The hardest situation is for kids who are going back into a college setting.
Hmm.
That's different. That's a much younger group. But for seniors, making sure that you have the appropriate support afterwards is very important. But in addition to that, part of what I do, in addition to the medical management, is bringing patients to the awareness that there are two people living inside their head, the addict self and the sober self. And if I can get them to delineate the difference, it makes it a lot easier. I have them make a journal and they have quotes. This is their quote book. And they're going to put quotes from their addict self on the left and quotes from their sober self on the right. And you have to think of the sober person is always right. Feels good to be right all the time, doesn't it?
Mm-hmm.
There's again another confidence booster. So somebody, the person, the patient, will come up with a name. I actually ask them to name their addict roommate so they
Really?
can really get a clear picture in their head that this is not who you are. This is somebody else. And I feel that the reason this exercise works so well is because it's a lot easier to say no to somebody else than it is to say no to yourself.
Wow, so
And when I bring
interesting.
this,
Yeah.
yeah, well, this is something that I really developed on my own. At my time at Maple Grove, I worked with Dr. Philippe Gilly, who I remember a very distinct conversation we had in the office one day, and he was describing addiction to me. And he said, when patients are in relapse, they are just in a different mode. There are no sets of words. There is nothing you can say or do. That person is in a different state of being.
Mhm.
And that sort of helped me realize that there are two people living inside your head if you are dealing with the disease of addiction. And I tell them, sober you brought you here. Sober you wants this kind of help. Sober you knows that this is the right way.
Yeah.
And then I use a series of metaphors and I tell them, if somebody came up to you in a Grim Reaper outfit, and told you what to do, would you do it? Well, the answer is no.
Mm-hmm.
But the addict you is your reaper.
Mm-hmm. Mm-hmm.
That is your reaper.
Yeah.
So
Quite an analogy.
having that understanding. Well, yeah. I mean, if you know that when somebody is speaking to you, it's not you, it is a lot easier to say no.
Right.
And I tell them that anything that makes you want to drink, anything that makes you want to drink is the addict you.
Mm-hmm.
That's your addict self.
Wow.
And then every day I have them write the date. Mhm. Right. And they have to learn how to identify who's speaking.
Mm-hmm.
And under any circumstance, any sentence that they hear in their head that makes them want to drink is the alcoholic self. And I tell them this is an important exercise because you need to realize that you are stronger than this person. and you can overcome it with that knowledge.
Yeah. Wow. Heavy stuff for sure. I wanted to ask you about your holistic techniques and, your breathing techniques. Does any of this come into play? And talk to us about that.
Absolutely. Absolutely, especially with regard to anxiety. Anxiety is a huge driver for relapse. And I always ask patients, why do you use, whatever the substance is, why do you drink? And almost always the answer relates to it takes the edge off.
Mm.
I say, okay, well, tell me about that edge. What is that edge? And when I really break it down, it's anxiety. It's something that has led to a frustration, a concern, a worry that can't be soothed by their current coping mechanisms, which is why we have to build those up. And that's what we focus on as well, coping mechanisms. That's where I refer to talk therapy.
Mhm.
And I always suggest people join some type of group meetings as well, because this is your fraternity. This is your brain trust. These are people who have walked walk and can solve your problems.
Right. I mean, one of
Holistic.
my questions, or my next question was, obviously you're dealing with this in a different way than, say, an AA meeting would, but you've just mentioned that. So go ahead and expand upon that.
Well, also to readdress your earlier question about holistic, I do treat with some holistic medications, and I do find that helpful. Patients who have abused benzodiazepines, they're depleting their gamma aminobutyric acid in the brain, which is the brain's keep calm hormone. So very often when somebody is recovering from that type of addiction and they've come out from either a rehab situation or we've done a slow, gentle taper, I'll often recommend some GABA, which is an over-the-counter supplement that patients can take to help raise up those stores. And it also works in the immediate, some calming relief in a way that's not dependent at all. I also use methylfolate. Methylfolate is a building block for dopamine, serotonin, and norepinephrine, which are all the regulators of focus and mood. So when people come to me and say that their antidepressants aren't working as well, a selective serotonin reuptake inhibitor, or an SSRI, such as Prozac or Zoloft, works by keeping the serotonin you do make around in the brain for a little longer, keeps you calm for longer. So if you just don't make enough, having something that's this building block can help you make your current meds work better.
Yeah. So believe it or not,
breathing.
we are almost out of time. I wish I could talk to you way longer. But tell us just give us some final thoughts. And we would love to have you back on to continue this conversation because there is so much more to talk about. But just some final thoughts.
Well, I think most importantly, if you or somebody you love is struggling and you think they're struggling, they might be struggling, have that conversation. It is so worth it. Every life is worth saving. People have asked me so many times, why do you do this? What is the reason? And I say Jimi Hendrix, Janis Joplin, Philip Seymour Hoffman. Do I need any more reasons? This world is a better place with these people in it. They're often the most creative, sensitive, artistic people.
Yeah.
And I think everybody is worth saving. Everybody.
Yeah. Yeah. Those are some kind words and good words. We thank you so much for being a guest on Gracefully Graying.
Thank you for having me.
Yeah, you're a wealth of information. And again, we'd love to have you back again and keep talking because there's so much to learn and people need to know about this. So we thank you
I'd love
for
to join.
Yeah, it was great. So thanks for watching Gracefully Graying. Please share us on YouTube by searching Gracefully Graying and go to our website, gracefullygraying.com. And Aliya, thank you again for being our guest.
Thank you for having me.